right, it is the top of the hour on February 9th, 2021, and here we are for ACMT Grand Rounds. Today we have Dr. Knut Erik Hovda, who's a specialist in internal medicine and emergency medicine with a PhD in clinical toxicology as well at Oslo University in Norway. And he's a consultant for the National Poison Control Center. He's worked with Doctors Without Borders since 2012, and he's developed a methanol poisoning initiative. I encourage you to look at his bio sketch and go to the websites. They're pretty awesome. He's done several field missions in that regard, and his primary research interest is in toxic alcohols, metabolic acidosis, etc. Today, he's going to be talking to us about methanol poisoning in 2021, and we're really excited to have him. Before I turn it over to him, I just want to remind everybody to, if at all possible, hold your questions for a question and answer period at the end. Feel free, though, to put the questions in the chat box. I'll try to collate them and bring them to Dr. Hovda's attention if there's something burning that needs to be clarified while he's presenting. But with that, I'll turn it over to Dr. Hovda. Thank you again for being here.
Thank you so much for having me. It's a great pleasure and it's a great honor. And I hope it's going to be worthwhile for all of you spending an hour to speak with somebody on the other side of the Atlantic. I have a whole lot of slides coming up, but I've done that on purpose. So if you want to, you can have the handouts afterwards for your reference. I'm going to skip quickly over some of them, but I hope that it will still be plenty of time to have some questions around afterwards. I have did not want to move, so why is that? Now, I have a disclosure. I'm a CEO and co-owner of the company Orphan Diagnostics, working on making bedside diagnostics tools for methanol poisoning. It's with the help of governmental research and innovation funding, and there is no commercial product available at present. I started out making this overview of the last 100 years of methanol poisoning. I just want as a start. And what you will see is that already in 1920, Harrop reported on acidosis and the effect of treatment with alkali in methanol poisonings. In 1943, Olaf Röhr had one of his important papers showing that ethanol inhibits the metabolism of ethanol and should play a central role in the treatment. In 1953, Bennett reported a big outbreak, and he downplays the role of early ethanol, but he claims alkali as being the most important part. In 1961, Austin and colleagues had the important paper on hemodialysis of methanol poisoning. Lee and Thorell published the first paper on 4-MP showing to be a powerful ADH inhibitor in 1969. In 1975, Professor McMartin and colleagues published one of several papers showing that formic acid was the toxic metabolite and not formaldehyde. Noker and colleagues published a paper on the role of folate in 1980. And in 1982, Professor Jacobson, my mentor, had one of his several papers in methanol, and this one was on the pulmonary excretion of methanol in man, showing that approximately 80% of the elimination of methanol is through the breath. Jeffrey Brent published the phase 2 and 3 trials of fomepizole in 2001 for methanol, that is. And in 2005 was the first paper where we had formate used as a diagnostic tool in methanol poisoning. Now in 2021, are we still going for the old school, or are we heading forward? Well, here are some short notes on what we know. Nope, poor distillation is not the problem with methanol, it's adding methanol. We know that if you distill your alcohol poorly, you will have some methanol coming out, but it's not much, and it's not relevant in this context. No, you will not get drunk from methanol. at least much less than ethanol, ethylene glycol, and especially much less than isopropanol. You will get somewhat dizzy from the osmolality, and but you will not get really drunk. And if you are, you should look into whether there are other alcohols around as well. And if there are, you will probably not have the toxicity from methanol. Nope, it's not dangerous to dialyze for more than 6 hours. And this question comes up from time to other because of the osmolality drop, the quick osmolality drop. There are two reasons why this is not dangerous. First of all, the osmolality increases very fast as well. So it's reasonable and it makes sense to take it down quite quickly. The other reason we obviously do it is that the alternative not to dialyze methanol poisonings makes a much more severe damage. No, methanol does not give you severe symptoms in less than 6 hours. And if your patient is in a coma within that short time notice, is not in a coma because of methanol. No, we do not know how big the problem is globally. As a matter of fact, it's much bigger than we think. Methanol is called the big imitator, and that is the reason, along with a lot of people with or a lot of areas with limited knowledge to methanol, makes this reporting very difficult. Yes, diagnostics are probably the most difficult issue, and is also one of the reasons why we spent a lot of time looking into this the last almost 20 years for my sake. And finally, no, the international guidelines are not possible to fulfill where the majority of the patients are. And that's why we spent much time to look into a more pragmatic approach to make a simpler guideline to where the patients actually are occurring. So what I want to show you right now is an example of a simplified approach I'm using for training purposes. And this started out predominantly from low and middle income countries, but now I'm using most of this approach also when I'm doing these lectures at home as well. And the reason for that is I believe a lot in understanding the main mechanisms and then leaving the other things behind so we can focus on what is clearly important. So you all know this very well. Methanol, ethanol, and ethylene glycol are all metabolized through the same enzyme. None of them are toxic. The toxic metabolites, formaldehyde and formate, or both of them are toxic, but formaldehyde has a very short half-life, and so formate or formic acid is the part we're focusing on for methanol. For ethylene glycol, it's the glycolic acid that gives us metabolic acidosis. A small proportion of that is further metabolized to oxalic acid, and where it binds with calcium and creates the well-known calcium oxalate crystals that promotes the toxicity. What we also know is that there is an early stage and there is a late stage of poisoning. The early stage is what was described by the early authors in the early 20s, where they saw that by providing a load of buffer to these patients, they would be able to treat the acidosis, and their patient would actually get their vision back. Their symptoms would be reduced. But for a reason, this poisoning is still called the metabolic or the bicarbonate resistant acidosis. And the reason for that is obviously the late stage of poisoning, where formic acid or formate gradually starts to inhibit the mitochondrial respiration. And by inhibiting that, you will have a tissue hypoxia. You would have a lactate production, you would have an increased acidosis, and the more acidotic you are, the more the toxicity of formate would increase. Hence, you'll have more tissue hypoxia, more lactate production, more acidosis, and at some point you find your circulatory failure. And the circulus hypoxicus is starting to run. And if you don't use your antidote, this wheel will spin faster and faster, and you will not be able to save your patient, given they have taken a significant amount of methanol. So how come toxicity of formic acid is so much higher than the formate? Well, first of all, it does inhibit the mitochondria more, or the cytochrome oxidase in the mitochondria much more than the ionized form. It also passes the blood-brain barrier, the cell membrane, and the mitochondrial membrane much easier as compared to formate. Meaning the more acidotic you will get, the more this reaction will be turned to the left. There will be more non-ionized formic acid. And given the pKa of formic acid, a drop of 0.3 of pH will actually double the amount of undissociated acid, provoking much more toxicity. Another thing you would probably be aware of, or at least some of you would be aware of, is that there is a reabsorption of formic acid in the kidney. Formate, however, is not reabsorbed, again meaning the more acidotic you are, the more formic acid you have, the more reabsorption, the less excretion, and vice versa. Because formate, this is similar to ion trapping that we are using specifically in other poisonings as well. But the formate ion is excreted in the urine, formic acid is not. Let's look into diagnosis. And again, I will just get briefly through it, and I will just leave you with some points that I would consider very important. The patient history, the clinical feature, and the analytical options is what we have. I tend to focus a little bit on the re-evaluation of these patients, because sometimes they've been drinking a mixture of ethanol and methanol. They have no symptoms actually pointing towards methanol. And then 12 hours, 24 hours later, the same patient may have a lot of symptoms. So I'm asking my colleagues to please remember this when they are considering these poisonings. More and more, I have been interested in and focused on the basics, and the patient history is probably one of the things we can get a lot of information where we actually forgetting it from time to other. I will not go into details now, but I'm asking you to remember that from intake to symptoms, it takes at least 12 hours to generate enough formic acid, often or usually even more than 24 hours to get significant toxicity. So if your patient has a shorter history than 12 hours with a lot of symptoms, it is due to something else. When it comes to clinical features, again, I will not stop very much or spend very much time on this, because most of them are quite unspecific. And one of the unspecific yet still very consistent finding is the hyperventilation. And remembering that none of our patients would be hyperventilating because they're happy to see us. They are hyperventilating because of a metabolic acidosis of whatever reason, being it a septicemia or diabetic ketoacidosis or a toxic alcohol. So it all starts by looking into the clinical features to make us trigger the rest of the diagnostic process. From there on, we have some analytical options. And again, I'm not going very much into details, but I want to mention a few things about each of them. As for the arterial blood gas, it's a phenomenal tool. It gives us a lot of information as long as we're able to interpret all the information that is in the blood gas. But remember, it tells us nothing about the origin of the metabolic acidosis as such. Also, you should be aware of that the majority of the places where these patients are, there are no metabolic or arterial blood gas machines available. The osmolar gap and the anion gap is again very helpful tools. We use them all the time. Again, remember they're unspecific and worldwide usually not available, especially the osmolality. The osmolality needs to be run on an osmometer or by the freezing point depression method. And I want to mention that in particular because regularly I see colleagues using the osmolality from the blood gas machine. You must never, ever use it. Why not? Well, there are two ways that the blood gas machine would give you osmolality. One of them is that it's not measuring it, but it's calculating it. And then it would calculate it from a fictive urea. The other way it's doing is actually measuring it, but it's measuring it by vapor pressure method, which will not detect the volatile alcohols, and you would have a false negative osmolality or a false negative osmolar gap, which is far worse than having none at all. The methanol analysis is, of course, thought to be the gold standard, and it is the gold standard as of now, but it's very, very seldom available within a short time notice. Even where we have it, like in our hospital, it still takes some time and sometimes longer than you actually have in terms of before you have to start treating your patients. Also worth noticing is that late in the course, methanol might be negative when all methanol is metabolized. Formate analysis is until now less available, but the good thing about the formate analysis, once you have it, is you know that your patient cannot have symptoms from methanol before they start to develop or get a certain formate concentration. So back 15, 20 years ago, we did some studies on this because we implemented the formate analysis in a diagnostic process because we found that this is an extremely simple method that can be implemented in spectrophotometry analyzers found everywhere. All you need is a formate dehydrogenase enzyme, and you can get this analysis done everywhere within 20 to 30 minutes. It's extremely sensitive and specific. You can measure formate down to endogenous levels. And you can also measure formate several hours before the patient even starts to have symptoms. Still, you are in need of a laboratory, and some places doesn't have that. So that's why we started to develop this simple tool, a very small and a simple dipstick, using a drop of blood with a separation filter. You have a reactive membrane, you get a color change, and within usually, or say between 3 and 4 minutes, you would have a semi-quantitative formate level, and you would be able to diagnose the patient. I'm just going to leave this here for reference. It's just a flow chart where you can easily use any kind of formate analysis on the bedside the patient and be able to diagnose your patient. Not spending much time on differential diagnosis, I want to spend a couple of minutes on the alcoholic ketoacidosis. And why is that? Because almost everywhere I go, there is a certain proportion of people, colleagues who's been working in toxicology, emergency medicine, intensive care, and has no reflection around the fact that there is something called alcoholic ketoacidosis. Well, let's look into that, because these patients are typically the same group of patients drinking toxic alcohols. There are people drinking a lot of alcohol. And among other things, we know that alcohol would typically give us a low extracellular volume, and with the alpha-adrenergic stimulation, it ends up the liver oxidizing alcohol to ketones. There are several mechanisms to why we have a lactate increase, thiamine being one of the important ones in this group of patients. And it's typically a low intake of calories, meaning the liver uses alcohol as an energy source, producing ketones. And while this is a simplification of the main mechanisms, the only thing we really need to know is that these patients' metabolic acidosis would be corrected as long as you give them intravenous fluid, thiamine, and glucose. Some of them might need a little bit of insulin as well, but this would I call it a fluid trial, would help you separate bedside these patients from the toxic alcohol within 30 to 60 minutes. And it's very, very helpful as long as you haven't given them bicarbonate already. Little brief look into the treatment. Again, let's do this simple. Remember this figure, remember the reaction. As long as we give these patients bicarbonate, we will run this reaction to the right. What we do will have less formic acid, more formate. We'll have less inhibition from formic acid, and formate will promote much less inhibition as compared to the non-ionized form. In addition to that, giving us more formate, we will have an increased excretion in the urine, and the half-life of formic acid would go down. How about the antidote? Again, my apologies for the very simple sketches, but this would help us enough to tell that the rationale for the antidote use is to stop the metabolism of the parent alcohol to the metabolite. The toxic metabolites is what we don't want. Now, there are two different antidotes, and I guess all of you are just considering the use of fomepizole for most cases. But it is a choice, and we have to choose between the two based on availability, outcome, the safety of use, the cost, not only from the antidote, but the overall cost as well, the simplicity of use, the availability of supplementary treatment, and sometimes we have to take into consideration other issues like religious ones. There are both efficacy and efficiency differences between the two, and let's have a brief look into it. When it comes to efficacy, fomepizole has a well-known higher affinity to the ADH enzyme as compared to ethanol. However, the prospective trials of fomepizole never compared the two. And there are only two bigger studies that has looked at the outcome comparing fomepizole and ethanol. One of them showed that there were a certain difference between a patient able to hyperventilate, but there was no overall difference in outcome. And the other study done in Czech Republic showed no difference in outcome at all, which means that in spite of the higher affinity of fomepizole, it's a similar outcome, but this is given ideal circumstances. And what is an ideal circumstances? Well, first of all, you should be able to measure your ethanol level because of the well-known difficulty of keeping it at a therapeutic level. And that is not the case in most places where they don't have fomepizole at all. There is a lot of ethanol side effects, which is common, and I'm not going to spend very much time on it. But the problem is, how do we dose the ethanol if we don't have any available ethanol level? Well, here is a simple suggestion, and this is based only on the concentration of alcohol, the weight of the patient, and whether your patient is a non-regular drinker or whether he or she is a regular drinker. You'll find here that you can use beer, wine, hot wine, or stronger wine, or liquor. Doesn't really matter. It all works, but you have to dose it accordingly. This is, again, just a sketch to show you one of many, many papers showing the very, very poor ability to reach the therapeutic level of ethanol. This is the methanol concentration, it's the ethylene glycol and it's glycolic acid. This is the ethanol infusion time, and this is the dialysis time. You see, it's hardly touching the therapeutic ethanol level at all during the whole course. And this is very, very common problem. So when it comes to practicality of using fomepizole, there are less side effects, and for pregnancy purposes, fomepizole is always recommended. Sometimes I'm talking to patients saying that they would not use ethanol for their pregnant patients because of the fetus. And I can tell you for sure that if you have a pregnant patient, you rather give them ethanol than nothing at all, because the formic acid toxicity is way beyond the toxicity of ethanol. Dosing of fomepizole is also well known, so I'm not going to spend very much time, but you might not be aware that there are new data coming up now. We're about to collect this data and finalize these data that telling us that you can dose fomepizole at every 8 hours rather than every 4 hours during dialysis. And we know that there is a clear pharmacokinetic rationale for that. You can also, if you're using continuous infusion of fomepizole, you can still go down to half the concentration, and you'll be more than safe. I can tell you that before this data is published. Another thing that you've probably not been thinking about is that if you have limited fomepizole availability, we're often thinking about this because if you have a lot of patients coming in and you have a limited availability, we have suggesting using fomepizole for the ones who need, for the first 24 hours, stabilize the patient, and then gradually turn over to the use of ethanol instead to save fomepizole for the ones for a higher number of patients. There are some other aspects. I mentioned the religious aspects, for instance, in areas where ethanol is not legal to use in the first place. And it's a humongous problem. I've actually spent some time focusing on that. What I'm focusing on is that ethanol in this context is not a recreational drug, it's actually medicine. And all these places have been where they don't want to use ethanol and they don't have fomepizole. They are still using ethanol in the cleaning, in the disinfection, cleaning their hands. And once I'm focusing on that, they're actually agreeing on that. And in the same regions, it's completely forbidden to use other recreational drugs such as heroin and opium and stuff like that. Still, they are using morphine for treatment of their severe pain. And when I'm again putting this into the same context, they seem to agree. And actually, most of them are changing their minds after these simple discussions. But we need to be aware of all these problems around elsewhere. Finally, regardless of the antidote you use, you should use it early and preferably actually pre-hospitally if you're in the middle of an outbreak and if there's a long transporting distance. This was done in Estonia in 2001, but they never managed to collect data. But in Czech Republic, we managed to collect data. And among 100 methanol poisoned patients, 30 of them got ethanol pre-hospitally, and none of them died from ethanol. And the simple rationale for that is to start early enough, and don't wait for a potentially long transporting time to a hospital before you start the treatment that would not at all be dangerous to the patient. When it comes to cost benefit, again, we have to look at both the cost of antidote versus the total burden. And in some countries like Norway and in the US, ethanol intravenously is also very expensive. The fomepizole access campaign, I'm going to mention for you afterwards what that is, so I'm not going to spend more time on that now. How about dialysis? Well, dialysis has a simple rationale. We want to eliminate the toxic alcohol, we want to eliminate the toxic metabolite, and we want to correct the acidosis. Then we have to ask ourselves, what kind of modality do we want to use? And before answering that, we need, or when looking into that, we need to answer 3 questions. How effectively does the various modalities eliminate the toxic alcohol? How effectively does it, and the toxic metabolite, how effectively does it correct the acidosis? And is there a difference in outcome? This paper clearly shows the difference in elimination speed from the intermittent dialysis towards the continuous modalities. It's more than 5 times as efficient to use intermittent dialysis as compared to continuous modalities. It's clearly also more efficient in terms of correcting the acidosis, but when it comes to outcome, it's a different story. It's actually no difference in intermittent versus continuous modalities when it comes to outcome. And what does that mean? Well, first of all, it means you can use what you have. Secondly, you would be still able, if you have both modalities available, which most hospitals in our parts of the world do have, we would still be able to use continuous dialysis if our patient is very circulatory unstable. That all being said, if it's my patient in my ICU, I prefer to use quite a bit of inotropes and pressors and rather use the intermittent dialysis to speed up the correction of the acidosis and get rid of especially the formic acid as soon as I can. But again, most importantly, use what you have. When it comes to peritoneal dialysis, it's a significantly slower elimination, but is not very well documented. It's probably only indicated if there's nothing else available, if the transport to dialysis facilities is not feasible, and finally, the procedure has to be well known for the treating doctors so that we don't cross the important medical rule of not harming the patient more than they manage themselves. This brings us over to the folic or folinic acid part. The rationale is again quite simple. Folate is a limitation in the human body. Most animals has enough folate in their body, so they would have enough substrate for these enzymes to continue to metabolize formic acid or formate, and methanol is not, therefore methanol is not toxic to animals. For us, we have quite limited amounts of folate in our body, which means that after quite short time, these enzymes would be saturated and formic acid would start to accumulate. So what we do is just add folate or folinic acid, which is the active metabolite, as you know. It's very simple, it has no side effects, and it's cheap. Trouble is that we only have the data from the lab and from some animal studies, and we do not really have outcomes showing the benefit of using it. And the obvious reasons why there is no RCTs testing this is that it would be a very difficult questions from an ethical point of view, because you would have to avoid giving them any other treatment until they got here, and some of them would then get folic acid and some of them would not. So I don't think that data would ever be present. But being very simple, having the theoretical benefits, and being cheap, it's still part of the international guidelines. And to my opinion, it should still be left there. There are some other treatment aspects as well. Transferring, for instance, dialysis and ventilator is often relevant, especially in the low and middle income countries. I say always remember to start the treatment, especially with antidote, before you start your transport. How long do we treat the patient with antidote? Well, if you don't have any methanol analysis, it's mostly recommended to treat with antidote 6 to 12 hours after ending your dialysis session, after a full dialysis treatment is given. If you don't have methanol analysis or dialysis available, then we again have to be pragmatic. What we have suggested is give ethanol for 5 days. Why only 5 days? Well, based on the half-life, you would never, ever be able to completely block the metabolism of methanol. And after 5 days, it's unlikely to be more methanol left. Then we suggest you stop, wait for a minimum of 24 hours to see if another acidosis develops. If it does, then treat for another 2 days and stop, etc. If you have fomepizole available, you need to treat them for at least 7, maybe up to 10 days based on the half-life. Then you use the same procedure and stop and keep them in-house until you make sure that they don't develop a new metabolic acidosis. How about the prognostic aspects? Well, we know quite a bit about that. Coma on admission and the degree of metabolic acidosis are well-known parameters from a prognostic point of view. Whereas by coincidence, we found that the ability to hyperventilate is quite a significant prognostic parameter. Serum methanol is not. And what does this mean? I will show you in a minute. These data I'll just leave you again for your references. Same with the ability to hyperventilate. This is from the Norwegian outbreak. This is from combined material from Norway, Estonia, and Iran. And this is from Czech Republic. And it's all the same. If you're becoming more and more acidotic without hyperventilating, it's a poor prognostic sign. And these very, very simple tools would actually make us able to say something about the prognosis within minutes after the patients are arriving. Look at the consciousness and the pH of the patient. Whether your patient is hyperventilating or not, giving a severe metabolic acidosis would make you able to stratify whether the risk of dying is in the 5% range or the more than 80% range within minutes with very, very simple tools. So what is the range of the problem? I think nobody knows. what I know is that all the outbreaks we are talking about is just the tip of the iceberg. You will see here that it seems to have been exploding the recent years. I don't really think that is the case. I just think that the number of reports are finally increasing. And while we are only seeing a small proportion of the fact or the reality, it's at least becoming better. There is more focus, especially in the media, towards these patients. These are not single cases. These are incidents or outbreaks, some of them being just a few, some of them being hundreds at a time. You'll find on this website, you'll find a link as well to many of these outbreaks. So what we did was back in 2012, we created the Methanol Poisoning Initiative. The Methanol Poisoning Initiative is a collaboration between Doctors Without Borders, Médecins Sans Frontières, and Oslo University Hospital. We're just a very small group of 2, 3, 4 people. We've already been to some intervention, a couple of them mentioned here. We've been in several countries doing capacity building initiatives. We developed protocols. We are working on the access to Fomepizole, and we're trying to develop a simple diagnostic tool. Many of our resources can be found on this website. You will find that there is a small video. I will probably not spend time to show you afterwards. You can do that. It's about a minute long. And we try to make a generic little video for the public to tell them when to go to hospital, when to ask for help. And this is extremely important. And it has been very well shown by Professor Hassanian and some of his colleagues in Iran, where they started to do this, what they call the active case finding. And they had an outbreak in Iran where there were about 5 to 10 patients showing up in a district. They called the local, the national authorities, who again sent out a massive apparatus to support them. They have already made this emergency preparedness plan based on after some earthquake incidents. And they sent text messages to the whole region that anyone been drinking spurious alcohol of any kind should go to hospital, and they would not be punished. Within less than a week, they had almost 800 patients coming in, and less than 10 of them died. And that is by far the lowest fatality rate ever seen, again, based on information to the public. In the same pages, you would also find this an overview of some of these outbreaks and with references to them. We've been making posters I would show you as well. And maybe most importantly, we have been working with several entities to make guidelines. This is from last year. This is a collaboration with the Cambodian Ministry of Health and CDC, with WHO and Doctors Without Borders. And we made, they had no international guidelines at all for these kind of treatments, and they had a quite massive problem with methanol. And these guidelines is very simple, and it contains a little bit about the background and toxicity of methanol, a little bit on diagnosis, a little bit on how to treat the patient and some prognostic aspects. Further, we have made some flow charts, meaning if you have a suspect patient and only have a blood gas available, you should be able to diagnose your patient with or without methanol poisoning. In case you don't even have a blood gas, this flow chart should be able to help you through. And I think that the kind of simple approaches is really, really helpful for us in our part of the world as well, to get it down to where we stop only relying on the analytical equipment we have and stop thinking from a clinical perspective. We've put in the use of formate and the dosing of the various treatment in the same protocol. And as you would see, we have also made a similar protocol finally last year for Doctors Without Borders It's a much longer process to get this formally accepted within the organization, but now it's there. The posters, these kind of posters, is now present in a lot of hospitals around the world in many different languages. To your far, or to your far left, you will see there is a timeline. There is sketches and text describing the symptoms and treatment for the various phases. And finally, there is a suggestion for dosing. And this is predominantly meant to have the people remembering that this is the case. And this is something that they should be focused on. Because if you don't think about methanol or ethylene glycol when you have the patients coming in, you would normally lose them before you find the diagnosis. As for the animation film, I'll actually think I'm gonna leave that for you, and or we can see it afterwards. It's about 2 minutes long animation film. I'd rather spend a minute or two to speak about the Fomepizole Access campaign. Back in 2012, we applied for WHO to include Fomepizole on the WHO essential medicine list, and in 2013 it was included. And that was the first step of this campaign, where we are the University Hospital, MSF, and WHO trying to get Fomepizole available in these places where we see these poisonings most often. We want to have the volume increased and the prices down. It's a long process, but we are fortunate in terms of having at least some of the producers being extremely positive. Because the way we see it, it would be a win-win situation. They would get the volumes significantly up, and we will get the prices down. We've been looking into local and national emergency preparedness plans from different point of views. And what is important, I think, regardless of where you are, but especially if you are working in a low and middle income country, you need to know where to treat these patients within your region. You need to know something about what kind of resources are available. And you need to know how and who to prioritize the patients, given you have dozens or even hundreds of patients in a short time notice. How do you deal with internal transport, and where do you get support locally, nationally, and internationally within a short time notice? These are all questions that I think from time to other we should ask ourselves. And based on these questions, this consensus statement was made, I think a couple of years ago. This was published with several US authors as well, and it's been about 20 experts from everywhere in the world who's been part of this paper. How about 2021 and the world as we know it? Again, you can find this Google sheet if you go into this link, and you will find a number of outbreaks, and within there that you will also find this outbreak. This is from last year, and this is from Iran. By the time this was published, there was about 5,800 patients, meaning at least 5 times bigger than the second biggest outbreak ever described in literature. This was during the COVID time, and this was in a hard hit COVID country. And in these regions with a lot of, where the COVID pandemic hit really hard, they had more people dying from methanol as compared to COVID. And why did they have all these poisonings? Well, clearly because they have seen the same as you have. There has been mixed methanol into the hand sanitizers. And in the beginning, they would start to drink this because they thought they would treat themselves. After some time, this was predominantly used as a recreational drug, and the availability was better than ever. And the people just started to die. And by now, there is more than 6,000 people dying in Iran only from these contaminated hand sanitizers. So as a summary, methanol causes thousands of fatalities, but it's not toxic by itself. Diagnosis is difficult, but it can be approached from various sides. Treatment is for sure effective, but we need an early initiation of the treatment to have a beneficial outcome. Overall handling requires emergency preparedness systems, and we should actually think about that in our everyday setting. Are we able to handle a number of poisonings? Handling can be done everywhere, but it does require a basic set of knowledge, and knowledge can take us a long way. Adaptation to local circumstances is crucial to have success, and you would know that from working in hospitals of different levels. You would see that it makes a tremendous difference in what kind of resources you would have available. So methanol poisonings. Yeah, it's still some old school, but we are most certainly heading forward. Thank you so much for your kind attention.
That was excellent. We have a few questions coming in. So the first one is, when can treatment be stopped in cases in which methanol level is known, referring to dialysis? We typically use a level less than 20 milligrams per deciliter, but we don't know if that's evidence-based.
No, but I think that most of the publications would be in that range as well. I think we are usually actually making making the methanol level based on the osmolality, and we're calculating back. And for most publications, we would see that about around 20 or 30 milligrams per deciliter, sometimes even up to 50 milligrams per deciliter has been said that you can stop dialysis, but you would still continue to give the antidote. But most places is conservatively 20 milligrams per deciliter, I would say. That's when they usually stop to give dialysis.
Great. Do you have a preference for folic acid versus folinic acid?
No, we use folinic acid because that is easily available as an intravenous substance, whereas if we're out in other parts of the world, we use folic acid because that's much cheaper and has a bigger or easier availability. Doesn't really matter. And if your patient is very circulatory unstable, you will have difficulty in estimating how much is absorbed from the GI. That being said, you could use it either intravenously or orally in most patients, and you should have the same effect.
And I wonder if you wouldn't mind just briefly reviewing how you approach redosing of fomepizole when a patient requires dialysis. I think you had a really great slide on that.
Yeah, so what we'll can look it back. Sorry, we'll go back to it. It should be no, that's too far. So what we know is that the elimination of fomepizole is much slower, clearly, in continuous dialysis, but the SOPs and all the protocols has left fomepizole on the same treatment protocols every 4 hours. So we started to look into that, and we actually have done, I think we collected now 10 patients where we've done this trial on, and the minimum level to consider to be effective for fomepizole is 10 micromolar or 10 micromoles per liter. The lowest concentration you would have when you are dosing them every 8 hours would be down to 70, 80, 100 micromolars. So you have from 6 to 10 times the concentration you actually need at the lowest point, even when you're treating them this after this protocol. So you will actually save quite a bit of fomepizole when using this this dosing regime instead, and is really completely safe.
Excellent. The
After, and yeah, sorry. A small other thing, because I know that there are different traditions in either giving every 12-hour when you're not dialyzing them, and every 4 hours during dialysis, and some would go over to a continuous infusion during dialysis, which is fine. To my opinion, usually I would be glad not to spend one of the intravenous line for the continuous course of the dialysis session, which makes me prefer using it every 4 or 8 hours, depending on kind of dialysis I do, rather than giving the continuous infusion. But they both work fine.
Excellent. The other question I have is if you could clarify for me. So you mentioned at the beginning of this talk that that adding methanol is the problem. It's not a poor distillation method. And you even, I think there were some dollar signs up on the screen at one point. Other than cases where methanol is in hand sanitizer and people are drinking hand sanitizer to get drunk, what other circumstances would people intentionally for profit add methanol?
So depending on where you are in the world, the reason for getting methanol poison is slightly different. In the where I live, the alcohol prices is kind of high, so there will be a lot of smuggler liquor or smuggler booze coming in from abroad, and they would from time to other, and we had some large outbreaks, mix methanol into this liquor to make more money when they're selling it. Simply because the alcohol is so expensive, and we actually had several outbreaks from that kind of source. And the difference from mixing methanol as compared to water or anything else that you want to dilute the alcohol with is that methanol would mix into the ethanol, of course. So if you leave your alcohol on the table, if you mixed it with water, after some time, it will separate. If you mix methanol, it will stay in there. You will not be able to see it, smell it, or anything. That was the same thing happening in the Czech Republic, where they actually found methanol to be put into liquor, original bottles, that is, in street vendors, in supermarkets, and in the bars. And after some time, they found the source to be somebody working at one of the factories producing alcohol. And they had bought tens of thousands of liters of methanol because it's much cheaper. It's used as a fuel and for industrial purposes. So it's always cheaper as compared to ethanol. And they were mixing it in, selling it both on the black market and the official market. If you go to, for instance, Iran, Indonesia, and several other Muslim countries, the legality of alcohol is the problem. So it's more difficult to get hold of regular alcohol, and the black market would increase because of that. So where you would actually expect to see much less methanol poisonings because they are not supposed to drink alcohol, that is one of the most prevalent places. And when I say in my country alcohol is expensive, it's also quite high salaries. In other parts of the world, alcohol is not that expensive, but the salary is extremely low, much lower as well. And again, you'll see them mix methanol in for commercial purposes or for economic or making money. That's the purpose. And the same thing in Russia, for instance. You'll find it in Africa, and it's the same ongoing thing. We see it in Europe as well, of course.
Excellent, thank you. Another question, for the treatment without dialysis, you recommended ethanol for 5 days, and I think fomepizole for 7 days or longer. Why not have the same duration for both?
Good question. If you look at the kinetics of methanol being when you block it with either ethanol or fomepizole, you will find that the half-life reported is 30 to 50, closer to 50 hours when you block it with ethanol. Whereas if you block methanol with fomepizole, you have a half-life between 50 and more than 80 hours. And the reason for that is that the competitive binding is much stronger binding for the fomepizole. You have a more complete binding, whereas for ethanol, the binding is not that much stronger as compared to the methanol binding. So you would at some point have a small proportion of the ethanol being metabolized still, and it's difficult to keep the therapeutic level constant in ethanol when treating them with ethanol. So at some point you will be underdosing and you start the metabolism, and there will be a shorter half-life. For all practical purposes, there will be less ethanol left as compared to when you're treating them with fomepizole, where you have a complete blocking. And we've had patients signing on to the ethical approval, and we're treating them for days on the fomepizole without dialyzing them partly because we were doing these kinetic study, partly because there were several patients coming in at the same time. And they were covered with all kinds of methanol analysis and formate analysis and blood gases, and they would not even have any kind of metabolism going on because it's completely blocked by fomepizole, and you're not able to do that with ethanol. So that's the background.
So does that mean you're saying that empirically you'd be treating with ethanol for longer than fomepizole, right?
No, shorter.
Okay.
Because if you have a certain amount of ethanol in the blood, you will not be able to treat them completely with ethanol. That's what I'm saying. Because your level will go up and down, you will have methanol being metabolized throughout the course of the treatment, and there will be less methanol left. So at some point, you don't know what your methanol level is. It might be 0, it might be 100 or 150. But the chance of that being 0 is much bigger when you treat with ethanol. So that's why you only need to treat them for a shorter period of time and stop after 5 days. Your patient should be stable enough to do that anyway. And you can either by running a simple blood gas analysis, or even by looking whether they are starting to hyperventilate. That would be enough for you to have an indication of that there after 24 hours, there is more toxic alcohol to be metabolized. So you would start or you reinsert the treatment again if there's more left.
Okay, thank you for clarifying. Do you have situations in which you cannot get either osmolality nor methanol level? And if so, what are your endpoints for dialysis and when to stop fomepizole?
Yeah, I would say the majority of the time I don't have osmolality at all or methanol levels at all. That does not mean at home. That means when we're out anywhere else. There is no such thing available. So our endpoint for dialysis, so the recommendation says at least 6 hours of intermittent dialysis. And again, we're doing this, having this pragmatic approach. So if you have a number of patients, for instance, we went to Libya in 2013, and it was a complete chaos. There were more than 1,000 patients in less than a week coming into the hospitals in one city. And added to that, there was a lot of patients dying outside of hospital because they were afraid of attending the hospitals. And we were looking into a sort of a strategy. How do we do it if we have a limited number of dialysis machines and a high number of patients, which is the case on a regular basis? Well, we suggested rather than having a 6-hour treatment time, we treat them for possibly 2 or 3 hours maximum, then rotate the machine, but keep the catheter in the patients and then rotate back, because you will be able to stabilize your patient, give them antidote, go to the next patient, and then go back, but with a total time of at least 6 hours of dialysis. And that should probably take somewhere beyond 95% of the method of the patients on a sort of from a sort of what do you call that, normal distribution curve. It would take the majority. Some of them would still have a little bit methanol left, so some of them might need another hour or 2, but the vast majority should be fine even after 3 hours or 4 hours. But having nothing, 6 hours.
Another question that came in, this is a question I had as well. Goldfrank's implies that methanol is inebriating, though less so than ethanol and ethylene glycol. Is that incorrect? I heard you say in the beginning it's not terribly inebriating.
No, it's not. It's not. For all practical purposes, again, you'll have a very slight inebriating value effect of it. It's very small. You will actually, the fact that you're increasing your osmolality quite quick, that will make you dizzy and somewhat inebriated as well, but it's not comparable to ethanol. And that is a general mistake made anywhere. So if you have people drinking a certain level of methanol, you will not find them to be very drunk. It's on the opposite side, you will find people drinking a whole lot of this, saying that I don't know why I didn't get drunk. I drank so much of this alcohol and I didn't get drunk at all. And I kept drinking. And we had people with a tremendous or significant methanol level being without being drunk at all. So inebriety, I would say no. Drunk, no. Inebriety, yes, very slightly. But I want to rather turn it over and say it's hardly anything at all, because it makes it possible to separate these ones from the really drunk patient who's been drinking ethanol and doesn't have symptoms from methanol poisoning.
So the questions are pouring in. I'm not sure that we'll be able to get to all of them, but I do have a hand up from the Arizona Poison and Drug Center, so I'm going to allow you guys to talk. Go ahead.
Hi, thank you for the great talk. Here in Arizona, we have lots of dry areas, dry counties or nations, and we run into this methanol toxicity often. However, we do not see hyperventilation early on because of the ethanol being on board and decreasing the hyperventilatory drive because of the ethanol. I was wondering if that's also seen other places, or you were suggesting that hyperventilation is always present in these patients.
It's not always. There are two exceptions. What I'm saying is it's a very consistent finding, which it is, as long as you have your metabolic acidosis. But as long as you have ethanol on board, they're treating themselves. So, but if they have ethanol on board and they're not hyperventilating, they don't have any methanol symptoms at all, because they're not creating any formic acid. So and that's why I said that you should be aware of the fact that this is a changing dynamic situation. So if you have a patient drinking a mixture of methanol and ethanol, they won't be hyperventilating until they are becoming acidotic. And they're not getting acidotic until the ethanol is gone. And then a number of hours before they gradually increase to hyperventilate. So you're right, some of them would not be hyperventilating, but either it's very early or they've mixed it with ethanol, and so they have no other symptoms, and they have at least 12, probably 24 hours until this gets serious at all. You have plenty of time. On the other hand, it might be those I was talking about who has a very poor prognosis, that they, in spite of their metabolic acidosis, are not hyperventilating. And whether that is the reason for them to dying or just sort of the effect that you're actually seeing that they are decompensating, at least it's a very poor prognostic sign. But both these exceptions are there, but the vast majority is hyperventilating, but it's only when you're acidotic. Hope that was the answer to your question.
Great, thank you very much. Oh, sorry. All right, I'm gonna be selective about the last question because we're over time, but this is just so compelling. The last question is, in patients with visual impairment, when do you get an MRI, and do the results ever affect your treatment?
Usually now we tend to take an MRI quite early after, when the patient is stable enough. So the last patient we had an extreme amount. She had, that was in September, October. She had a methanol level of 600 milligrams per deciliter, and she was highly acidotic. We treated her, we started the treatment still early, I mean, within a very short time after she was admitted to the hospital, even if they didn't know it was methanol. But she was blocked with fomepizole. She got dialysis, and she woke up. And after she woke up, she had no clinical features at all, no visual disturbance, no nothing. And I had to discuss with her to convince her to do the MRI. And she said, sure, I'm fine. That's okay, but I have no symptoms at all. But we went to the MRI and she had plenty of findings in the, still in the, on the MRI scan. So usually what I would do, if it, at least if it was at home, I would do this MRI as soon as, but partly for academic purposes as well. I would do it as soon as I can when they are stable enough to go to the MRI machine. Then I would do a follow-up after 2-3 months or something to see